Okay, so thank you so much for coming to talk to me today about your work on sleep problems in refugee populations. So this is obviously a very relevant topic with the ongoing war in the Ukraine at the moment. So we're very interested to hear about the work you've been involved in. So first of all, could you just tell us a little bit about yourself, so sort of what your background is and where you're currently working?
Yeah. So my name is Lone Baandrup, and I'm a medical doctor, and I have been involved in both research and clinical work for many years. I have a PhD and a Doctor of Medical Sciences degree in pharmacological treatment of schizophrenia mainly, but studied sleep within this population also. And I performed sleep examinations as part of a medication trial in patients with schizophrenia as part of my postdoc studies. And so since then, I've been very interested in and performed several lines of research regarding sleep and circadian rhythm disturbances in patients with different kinds of mental illness. And as part of this, I became involved in this study, which investigated sleep in trauma-affected refugees. I currently work as a consultant psychiatrist and head of clinic at a large mental health center in Copenhagen in Denmark, and is affiliated with the University of Copenhagen as an associate professor.
Okay, great. So first off, we're just sort of getting to know the sort of population. So how common are sleep problems in refugees sort of as a rule, and are they sort of different to what we see in perhaps other populations?
Yeah, well, refugees are at a high risk of developing PTSD and as such developing sleep problems and the disruptions in sleep. And disturbances of sleep are also prevalent as part of more acute stress reactions. So before the development of the PTSD, and sleep problems, especially in insomnia before a traumatic event, has been shown to increase the risk of prolonged reactions to traumatic events, including PTSD. And also sleep problems and insomnia in the period after a traumatic event has been shown to increase the risk of developing PTSD. So it is prevalent in this population, and probably a focus on the restoration of a normal sleep can help to prevent the development of prolonged traumatic reactions.
Okay, great. And so there's a couple of studies. Well, I think it's one study, but there's a couple of papers you published looking at the treatment of, and am I right? It's refugees with PTSD specifically.
Refugees with PTSD that were referred to a specialized clinic for treatment of the PTSDs.
Okay, and then you were looking at sort of sleep within the context of that. So can you tell us a bit about the study and who you were looking at and what you were doing?
Yeah, and as you say, both the publications that we refer to here are based on the same study. Which was a large randomized controlled trial. And the subjects included here, as you just said, were trauma-affected refugees with PTSD, which were referred to the specialized clinic that we have in the Copenhagen area for a specialized center for patients with PTSD and especially coming from different countries and with different cultures. And for publications specifically about sleep as a risk factor, we were especially interested in the specific role of sleep in relation to PTSD symptoms. level of functioning and the treatment response in the first of these publications. And the other publication is sort of the primary publication from this from the study, which reports the efficacy of the treatment that we investigated, which was image rehearsal therapy and meandrin as add-on treatment to treatment as usual in this specialized treatment center for patients with PTSD.
Yeah. So could you just tell us a little bit about those two treatments, just for perhaps people who are not sort of familiar with them?
Yeah, so image rehearsal therapy is derived from cognitive behavioral therapy, and it aims to train the patients in an alternative dream content to replace the nightmares, which are often connected to specific traumatic events. So the therapy is about training another dream content to get rid of the nightmare that keeps haunting these patients. And this treatment is recommended as the first line treatment for treatment of nightmares in the PTSD. It has shown promising results in patients with PTSD by improving total sleep time and sleep quality, and also actually by improving symptoms of PTSD.
Okay.
And so the second specific treatment that we investigated was meandrin, which is a sedating antidepressant. It's a noradrenergic and specific serotonergic antidepressant, which resembles mirtazapine, which more people probably know, but it has a shorter half-life. And so it has a sedating and hypnotic effect via an antagonistic effect on the histaminergic and noradrenergic alpha-1 receptors.
Okay.
So there was the two specific treatments that we investigated.
Yeah.
And the image rehearsal therapy were planned as 6 sessions, and meandrin was 10 milligram at night, and the dose could then be increased according to effect and side effects to a maximum level of 30 milligrams during the treatment.
And importantly, these were used alongside treatment as usual, as the
these were add-on to treatment as usual. Which and treatment as usual was a multi-component treatment strategy consisting both of medical treatment and physiotherapy and of the therapy with the psychologist. So this was a multi-component treatment strategy where the patients are usually affiliated with this specialized clinic for about one year.
Right. Okay. Yeah. Well, so since we're talking about the different treatment options, maybe we can sort of discuss those findings first. So what did you sort of find in that main analysis in terms of whether there were benefits of these add-on treatments?
Yes. The primary outcome of this randomized controlled trial was the subjective sleep quality of the participants. And it was evaluated by the Pittsburgh Sleep Quality Index, which is a broad measure of subjective sleep quality. And secondary symptoms included then symptoms of PTSD and depression symptoms, level of functioning, and subjective well-being. And then we looked for differences, of course, between the specific treatments, and we both had a treatment arm where image rehearsal therapy was added to the treatment as usual, and an arm where meandrin was added, and an arm where both the treatments were added, actually, because we hypothesized that the combination treatment would be superior to add on with each of the treatments. Yeah. But the only significant finding in this trial was actually for image rehearsal therapy on the level of daily functioning, while there were no other beneficial effects when compared to treatment as usual. Okay. So in that sense, it was a negative trial. We looked, of course, at the at the compliance and the adherence to the treatments, and they were both very low to the specific add-on treatments. So to image rehearsal therapy, only 39% participated in at least 4 of the sessions, and for meancerin, where we measured the plasma levels, only 34% had plasma levels that indicated that they had taken the medication during the trial. So therefore, the effects might have been underestimated in this trial because the adherence rates were so low. And of course, these results call for further exploration of the motivation and the ability of refugees to participate and take part and benefit of these kinds of treatments that we offered.
And I think actually it's a very important finding from the study that, you know, we've really got to think about how these treatments are feasible in such populations and how they're delivered and yeah, sort of if there are other ways of targeting such populations.
Yeah.
And I think that's something that hopefully people are considering in these sort of times with refugees coming into their services. Okay, great. So maybe we can then just sort of focus on the other study for a little minute, which was then looking more globally across all treatment options and looking at the effect of sort of prior sleep quality on treatment outcomes. So what did you sort of look at there and find in that analysis?
Yeah, this analysis, we tried to evaluate if we could see any specific effects of the intensity of sleep disturbances and the improvement in sleep disturbances both early and late in the study, to see if they were related to the improvement in PTSD symptoms. And so we found that in the study, looking at baseline data and also the follow-up data, that PTSD treatment response was closely related to improvement in general well-being and also an improvement of sleep quality, both in the early phases and in the later phases of the study period. And we found that improving sleep quality could be labeled as a modifiable predictor of PTSD treatment response, but that this effect was not entirely specific, but partly mediated by improvement in a more general mental state well-being. So we found that probably making specific efforts to improve the sleep quality will enhance treatment response in general in terms of improvement of PTSD symptoms. But that part of this effect was mediated by improvement in a more general mental state well-being. But still, we believe that the studies indicate that it is worth targeting disturbances of sleep in a specific way, because this is actually we have some treatment options and therapeutic treatments options to address sleep quality and sleep disturbances, whereas improvement in general mental state well-being is of course more complex. So exactly which intervention do you apply to improve the more general well-being? Yeah, sleep is more specific in that sense.
Yeah, great. And so I guess sort of taking it sort of a bit broader and thinking about kind of other sort of refugee populations that are obviously coming into various countries across Europe at the moment. Have you got any sort of thoughts or advice on what we can be looking at? And I guess from what you're saying, we need to be thinking about sleep problems in the context of trauma and sort of treatment of all sort of traumatic post-traumatic reactions, not just looking at the sleep in isolation.
Yeah. Yeah, well, I believe that we know we know that sleep problems are highly associated with the level of symptoms and level of functioning, quality of life, and responsiveness to treatment. So therefore, early interventions towards stabilizing sleep might actually be able to improve more global outcome of these refugees entering Europe now from Ukraine.
Mm-hmm.
And even though improving the sleep was not an entirely a specific intervention here in our study, as I just mentioned, sleep is a modifiable sleep factor.
Mm-hmm.
I think also it would be relevant to consider whether the sleep complaints are due to disrupted sleep continuity.
Mm-hmm.
Troubles falling asleep, awakenings after falling asleep, reduced total sleep time, or nightmares, since therapeutic interventions might differ.
Mm-hmm.
And refugees here in the acute phase will typically present with acute insomnia, and I think that there is a potential benefit here in terms of a better global outcome. If care is taken to support and stabilize the living conditions, so that the general stress level and arousal level can be reduced, and in that sense, a more normal sleep pattern can be restored.
Yeah, absolutely. And then something else I've been thinking about recently is the fact that obviously the majority of refugees are going to be women, children, and older adults. Is that something we need to think about specifically as well with thinking about sleep and treatment for sleep in this population, or not too much?
Yeah, we didn't really make any, sub-analysis or investigations in our sample whether there were differences between women and men. We know that sleep is prone to disrupt or at least change with age. So older people might be even more fragile to develop insomnia in reaction to traumatic events. And in children, I believe it is that the comfort and the stabilizing of the environment, making them feel safe to reduce their stress is the most important intervention compared to more specific interventions like those we tested in our study.
Yeah. Okay. Well, great. Well, thank you so much for giving us your insight into those studies and more generally. And yeah, thank you so much. And we look forward to hearing what new research you do in the future.
Yeah, you're welcome. It was a pleasure to be with you.
Thank you.